Welcome everyone. My name is Dr. Ben Buchanan. I am a clinical psychologist and CEO of NovoPsych, and I'm absolutely thrilled to be hosting tonight's webinar, or for some of you, this morning's webinar on the shortcomings of the DSM-5 and an alternative approach to assessment and classification. Here at NovoPsych, we love running these sessions because they give us a chance to connect with people who use NovoPsych and the mental health community. Psychologists, psychiatrists, counselors, social workers, CBT therapists, GPs, and mental health professionals around the world who are passionate about improving care and who know that high quality assessment is an important part of that. So the structure of tonight's webinar, we'll have a presentation by Associate Professor Miri Forbes, and then I'll be demonstrating a new measure called the Brief Hierarchical Taxonomy of Psychopathology measure, or the HiTOP. And then we'll do a Q&A and discussion at the end. And so do stick around for that, because I reckon Miri's probably got a lot to say that doesn't fit into her presentation. So I'd like to introduce our wonderful guest presenter tonight, Associate Professor Miri Forbes. Miri is a leading researcher in the classification of mental disorders with an internationally recognized track record in advancing evidence-based approaches to alternatives to traditional diagnostic frameworks. Since being awarded her PhD in 2014, she has produced a substantial body of peer-reviewed research and has shaped the field's understanding of the structure of psychopathology. Indeed, I see Miri's papers popping up all the time. Her work draws on large-scale epidemiological clinical data sets to identify the underlying dimensions that explain why symptoms and disorders so often co-occur. And this research has contributed to the development and refinement of the hierarchical taxonomy of psychopathology. She's completed fellowships at the University of Minnesota, the Center for Emotional Health, and Macquarie University, supported by prestigious awards such as Macquarie University's Research Fellowship and NH and MRC Investigator Grants. She's authored numerous high-impact publications in leading journals, with her findings cited widely across psychology, psychiatry, and public mental health. And I think she's also an all-round friendly person. So, hey, welcome, Miri.
Thanks, Ben. What an introduction.
Well, I was, when I was writing that intro, I looked you up online, and I found that there was not, you hadn't written a really complimentary introduction to yourself. So I
Yeah,
had to
true.
write one for you.
Thank
Usually they're easy to find.
you.
So Miri, thank you for being here tonight and preparing this presentation. I wonder, before I hand over to you, when did you first realize that the DSM was deeply flawed?
Probably when I started working with the HiTOP crew, I would say. So around 2015, I reckon, the last 10 years. And it was only really in working with that group that I understood why it was such an important priority, and have learnt a lot since then. But that would have been the first time I maybe started to appreciate the depth of what I see as the problems.
Right, so you've been trying to undermine the DSM and the predominant paradigm for about a decade now. How's it going?
Yeah, it's going well. No, I'm only joking. I wouldn't say trying to undermine. Let's say complement,
Complement. Very good.
strengthen the
Strengthen.
traditional approach.
Right.
And yeah, I think that there's reason to be optimistic.
Great. Great. Well, I'll pass that across to you now, Miri.
Awesome. Thanks, Ben. Um, Before I start, I'd like to acknowledge that I'm joining from the very beautiful and unceded lands of the Wallumattagal clan of the Darug Nation, and pay my respects to their elders who nurtured this land, water, and community since the Dreamtime, and extend that respect to all First Nations people. I'd also like to add some provisos before I speak today, because I think that a really big piece of context is that I'm not a clinician. I'm an academic researcher. I'm not clinically trained. There are loads of really clever clinicians working in this space. And so when I talk about clinical work, I'm usually drawing on their work, and I'll try to stay in my lane and highlight when I'm maybe wandering into the clinical space in the inferences I'm making. I do sometimes also get a bit lost in jargon because I work in this space, what we call quantitative classification. And so feel free to ask clarifying questions as we go. Like Ben said, Ben can stop me, and we have lots of time for questions at the end. I'd rather do that than leave people behind as we go. And then the other thing is, it's not a very well referenced talk. It's pretty self-indulgent. It mostly focuses on my work. There are a few references on the slides as we go. But if at the end there's specific points you're keen to read more about, like in the research literature, just feel free to let me know in the chat or Q&A, and I can put together some suggestions for papers. So just wanted to flag those things before we jump in. Yep, I'm Miri Forbes. I'm an associate professor here at the School of Psychological Sciences at Macquarie Uni and in our new Lifespan Health and Wellbeing Research Centre. And I'm very excited to be here with you all today. Thanks for taking time out of your day to go through this together. The big picture context for what we're talking about today is this idea that we're not making enough progress on mental health, right? Spending on mental health related services is increasing over time. The number of people accessing treatment is increasing over time, and spending on mental health research is steady, which will take in the current global funding environment. But even in that context, the prevalence of mental disorders and distress is increasing. A lot of people don't respond to existing treatments, and this isn't really changing with time and progress. And we're not making big breakthroughs in finding new treatments. And this really raises the question, well, where are the breakthroughs, right? We can now map the human brain with impressive detail, and we've sequenced the human genome. And both of these breakthroughs were around the turn of the century. And everyone was kind of expecting that that would lead to an understanding of the causes and solutions to mental illness. So the National Institute of Mental Health in the US invested really heavily in these breakthroughs in this period that Tom Insel was the director, so from 2002 to 2015. And this is a quote that he has reflecting on his time as director. He says, "I spent 13 years at NIMH really pushing on the neuroscience and genetics of mental disorders. When I look back on that, I realized that while I succeeded at getting lots of really cool papers published by cool scientists at fairly large costs, he estimates about $20 billion were spent, I don't think we moved the needle in reducing suicide, reducing hospitalizations, or improving recovery for the tens of millions of people who have mental illness." And I think that's pretty remarkable, right? That's more than a decade of focused research in these spaces that we were anticipating breakthroughs. And it's the world's biggest funder of mental health research, and we didn't move the needle. So I think this really raises the question, well, why, right? Why are we not making the breakthroughs? And there are a lot of possible reasons. My work is based on the idea that we have the psychopathology, the mental illness side of the equation wrong. And this really comes down to the way that we diagnose and classify mental disorders, classification. So the classification of mental illness drives research by defining the constructs we study. It shapes clinical assessment and treatment planning, and it affects funding priorities and policy. I expect that many people here today are familiar with the DSM, but we can just quickly look at the example of major depressive disorder, or MDD, in the DSM. Essentially, the way that it's set up is to determine whether a disorder is present or absent, that categorical distinction, based on whether someone has enough of the criteria or the right criteria. So for MDD, we've got these symptom-based criteria. People need 5 or more of the 9 criteria in the past 2 weeks. You have to include the first or second one. You also need clinically significant distress or impairment. There's exclusion rules that a lot of people are familiar with. These symptoms can't be attributable to the effects of a substance or another medical condition, for example. And this kind of approach that was introduced in the DSM-3 in 1980 really brought order to chaos by specifying those diagnostic criteria to define each disorder. It standardized diagnosis globally, which massively improved the reliability of research and provided a common language for people to refer to the same constructs through those clear definitions. So different research groups prior to the DSM used to, for example, study schizophrenia, but they were using the term to mean different things because there wasn't that symptom-based operationalization of diagnoses. So by taking that approach, the DSM provided a really valuable resource for the field. Unfortunately, we've become really wedded to and bogged down by these diagnoses now. There's no standardized criteria for how diagnoses are defined or included in the DSM, and once they're in there, they're really hard to change. So we now have these deeply reified, is what we call them, constructs that are baked into mental health research and practice, and it's a particularly big problem because of a number of prominent limitations. So we'll go through some of those tonight in some detail. One of the first limitations that got a lot of attention in the new era of the DSM was this idea of comorbidity, when we see two or more disorders presenting together. So we can take, for example, MDD and GAD. We have about a 3% population prevalence rate of GAD in Australia, but 30% of people with major depression have GAD. So that's 10 times the rate that we would expect by chance if the disorders were independent. So it challenges the idea that they're truly distinct categories that exist in nature. Comorbidity is the rule rather than the exception in clinical populations. So sometimes you'll hear people talk about the rule of 50%, that about half of people with a diagnosis have a second diagnosis and about 50% of those people have a third, etc. And so, yeah, this really challenges that idea that they're distinct categories in nature. But what this means in practice is that people rarely fit neatly into a single diagnostic category. Instead, they tend to meet criteria for multiple diagnoses. So when we design studies that test how well a treatment works, let's say for MDD in this example, if we include people who only have MDD and exclude the people with comorbid diagnoses, then the generalizability of those results to the real world populations where comorbidity is the norm is compromised. And if instead we include people with comorbid diagnoses, then it's really hard to disentangle the effects of those co-occurring conditions. And that limits what we can learn from the results if we're designing studies around these constructs. Another limitation is the idea of symptom repetition, where we see the same symptoms repackaged again and again throughout the DSM. So my team spent about 5 years working on mapping the repetition of symptom among the sets of repetition of symptoms among the sets of diagnostic criteria described in the DSM-5, and I'm just going to take a couple of minutes to walk you through what we did. We'll go back to this example of major depression. Actually, we draw on this quite a few times. But essentially, let's imagine that we pull out the DSM and go to section 2, right, where all of the diagnostic criteria are listed, and we read it front to back. That's basically what we did. We looked at the diagnostic criteria for each diagnosis and extracted the individual symptoms. So here we've got depressed mood, diminished interest, diminished pleasure, weight loss, weight gain, decrease in appetite, increase in appetite, insomnia, hypersomnia, etc. And we stripped each of those symptoms out. So we removed cause, frequency, causes, and consequences, just isolating the core symptom in each case. And then we laid them out in a spreadsheet. So here, those 9 diagnostic criteria were broken down into 20 distinct symptoms for depression, for example. When we did that for all of the disorders, it gave us a list of 1,419 symptoms that made up 202 different diagnoses. And this circle here, you can see along the circumference, the tiny little dots. Each dot is a symptom. So that list is laid end to end in the circumference of the circle. So once we had the list of symptoms, we then moved on to coding repetition among them, right? So here, this link is showing a symptom repeating at 2 places along the circumference. We use qualitative content coding and natural language processing to boil down all of the repetition into a list of unique symptoms. So here you can see all of the links, and we found that among those 1,400 odd symptoms, there were 628 unique symptoms in that list. 231 of them repeated 1,022 times, and this results in a third of the diagnoses having no unique symptoms that differentiate them from other disorders. So essentially, adult psychopathology, which is what we focused on here, is really rearranging the same 628 symptoms into 202 different patterns. If we think about some concrete implications of this, we can use MDD again as an example, because by far the symptoms that repeat the most throughout the DSM are the symptoms of MDD. So here in this plot, we've got each ring represents a chapter of the DSM, and the little circles are the symptoms. So it's showing how symptoms repeat throughout different chapters, like different families of disorders. And you can see on the left that those highlighted ones up the top are the ones that repeat most frequently. So we have insomnia occurs in 22 different diagnoses across 8 chapters, difficulty concentrating in 17 diagnoses across 7 chapters, etc. And so this was a pretty striking finding that the symptoms of major depression repeat so commonly throughout the DSM. We dug a little bit deeper and found even when we exclude all of the disorders with major depressive episodes in the criteria and all of the depressive and bipolar related disorders, right, trying to knock out things that you would expect to have that symptom set, we still see that 14 of those 20 symptoms repeat in 34 other diagnoses and span 8 different chapters. So basically, there's a lot of non-specificity in these symptoms, and that's bad for diagnostic accuracy, right? It makes it easy to misattribute symptoms of a different condition to depression or vice versa. And it means that comorbidity is likely to be inflated as well in symptoms that have those diagnoses. So the key takeaway here is that when we're thinking about limitations of the DSM, comorbidity is similar in that symptom overlap blurs the boundaries between disorders. Another big limitation in this space, my brother describes our style of speaking as like trying to drink from a fire hose, so I'll try to slow myself down. Another big limitation is diagnostic heterogeneity. And this means that many of our diagnostic labels don't carry systematic meaning. We can look at an example here. We can have 2 people with no symptoms in common that have the same diagnosis. This is because of that checklist approach, right? So in major depression, you have to have 5 of 9, which is a majority. But because you can have criteria like insomnia or hypersomnia, you can quickly end up with symptom profiles that have no symptoms in common. And this is a problem because if we're not grouping similar people using diagnostic labels, then when we try to compare people with versus without something like major depression in a case control design, it doesn't carry systematic meaning. It's really hard to find underlying mechanisms or effective treatments. So for example, we found that for major depression, there's more than 100,000 different combinations of symptoms that can meet criteria to get that diagnostic label. And for heterogeneous diagnoses like these, there's a really big reduction in the clinical utility of the label and a big increase in the noise in our signal when we're designing our studies around these constructs. So at this point, you may have noticed I'm relying pretty heavily on the limitations of major depression specifically. So we're going to take a quick detour to look at some other disorders here, just because I think it's interesting. So here, we're looking at some information on what I would call descriptive heterogeneity. So both what's possible in theory when we look at all the different ways symptoms can be combined from the diagnostic criteria, but also what we observed in a big data set that my team collected recently. For a bit of context, the data have high representation of people who are in treatment for their mental health and with a history of treatment for their mental health as well. But we don't have structured clinical diagnoses. And so that means that we're looking at self-reported symptoms that align with those symptom-based criteria for each of these diagnoses. So we're going to break down this first one slowly to orient you to the information and then look at some other examples. For specific phobias, there's 3 symptoms in the diagnostic criteria, which have 3 possible profiles because people can avoid, endure, or avoid and endure the phobic situation or object. So that's how you end up with 3, even though this is what we call a monothetic diagnosis where you have to meet all the criteria because there's, again, those combined symptoms. It lets us have 3 possible profiles. And all of those profiles were observed in the 908 participants in our sample who had symptoms that aligned with the diagnostic criteria. None of those profiles were unique to a single person, so they were all observed in multiple people in the sample, and nearly half of the sample, that subsample, shared the most common symptom profile. So here we're seeing quite a bit of homogeneity, still heterogeneity in the way that symptoms are expressed, but it's giving us a starting point. This is the most homogeneous diagnosis that we're looking at. Social anxiety disorder is similar in that it's monothetic and it has 3 possible profiles, 3 different profiles observed. None of the symptoms were unique to a single person, and more than half of the sample shared the most common profile. So for both of these, the most common profile was the anxiety. So here, social anxiety, fear of negative evaluation and avoidance, but not enduring the situations. The same for specific phobias, avoiding but not enduring the phobic situation or object. And then we start moving into more heterogeneity as we get more complex symptom lists in the criteria. So for agoraphobia, there's 10 symptoms that can form 392 possible profiles. We observed 125 of them, and more than half of those 125 profiles were only observed in one person, right? Each unique to a single individual in our sample. And here, the most common symptom profile was observed in 17% of the subsample. It was similar for generalized anxiety. 11 symptoms can form hundreds of possible profiles. We observed many of them. A bunch were unique to a single person, and the most common symptom profile was shared by a minority of the sample. But then we can move into more heterogeneous diagnoses like MDD and PTSD. We talked about MDD, right? We have more than 100,000 possible profiles. We only observed 1,000 because we had 1,200 people who had symptoms aligning with diagnostic criteria. And that meant that nearly every single one was just seen in one individual. So there wasn't like a prototypical profile that emerged. And in PTSD, this is showing that I don't always pick the worst example as I'm going through talking about these limitations. There's more than 46 million possible profiles. Nearly every single observed profile was only observed once, and the most common profile was shared by 5 people. So I just want to show this as an example showing that the limitations apply to varying degrees to different diagnoses. But we aren't really seeing, even in the most homogeneous diagnoses, we're not really seeing prototypical symptom profiles emerge. So diagnostic heterogeneity is pretty common as a limitation. So together, these 3 limitations speak to what I would call the poor validity of the diagnoses, that we're not measuring true constructs that like exist in nature. They have poorly defined boundaries. And there's another set of limitations that really speak to the reliability of the constructs. One is this idea of low inter-rater reliability, so that different mental health professionals often assign different diagnoses to the same person. And this was really clear in the DSM-5 field trials, where 40% of the diagnoses didn't meet the minimum acceptable level of inter-rater reliability. And this is related to those blurry boundaries between diagnoses that we've just been talking about. The thresholds that define whether a person meets enough of the criteria to get a diagnosis are almost completely arbitrary across the board, as far as I'm aware. I heard an anecdote from someone who was in the room when they decided that 5 of 9 criteria sounded about right for MDD. It's not derived from data and empirically supported, for example. And these arbitrary thresholds also result in diagnostic instability, where we can have change in a single symptom that means the difference between meeting criteria for a diagnosis and not having it. So the fact that we have low reliability and low validity really undermines the clinical utility of these diagnostic constructs and the research accuracy using them to design our studies. And that's the 2 primary aims of classification, so a pretty big problem. I've just got a quick visual demonstration of those reliability ideas, right? If we think about a dimension of symptom severity from low to high, and then we have an arbitrary threshold dividing members and non-members, it means that we can have an individual who meets criteria, and a small change means the difference between not meeting criteria, right? You can see them flipping across this threshold. So taken together, this means that if we take a heterogeneous group of people, they have different symptom presentations, different patterns of comorbid diagnoses, and then we group them to try to understand a construct like major depression. We want to understand its risks, causes, consequences, mechanisms, or treatment, for example. These limitations blow up those efforts. So because of this, there's a growing body of evidence that traditional diagnoses are misaligned with key mechanisms in neuroscience, molecular genetics, biological psychiatry, and clinical psychology, and that's really slowing progress towards identifying the causes of mental illness and improving treatment outcomes. So when we study groups of individuals based on their diagnoses, we lose a lot of valuable information. And I think of this as DSM disorders were a good place to start developing our understanding of the nature of psychopathology, but that they're not a good place to stop. So this is a bit of a chapter change, moving on to thinking about what's the alternative, and might be a good time to take some clarifying questions if there's some.
Yeah, Miri. Wow, lots of numbers, lots of interesting stuff. It does
It's dense.
highlight some of the things that you're grappling with, some of the questions. Cassandra here asks, well, she says that she works in the NDIS disability space, and having clients with comorbidity is the norm rather than the exception.
Mhm.
Um, she asks, how do people with disabilities, are they less likely to fit neatly in the box, in DSM boxes? And also makes a comment about people with disability missing opportunities for funding or for a diagnosis because they don't fit in the box, and therefore the utility of the diagnosis being to access funding gets lost.
Yeah, I think that's a great question, and I don't have a strong answer for it because I don't know the research in that space. I would imagine that potentially with more complexity in presentation and with more comorbidity, because that means that you're likely to see more presenting symptoms, it's going to get harder and harder to find one or a few diagnoses that can really explain or capture someone's experience. And so I can imagine that, yes, with more complexity and greater severity and comorbidity, it does make it more likely that people don't fit into a neat box tidily. And that, yes, that does undermine, or the fact that people often don't fit neatly really does undermine that utility of what we use diagnoses for. I agree. I think that's a good
And
observation.
interestingly, when the NDIS came out, they said that they weren't interested in psychiatric diagnoses, and they were interested in really the human and person-centered, and they didn't want to just categorize people with these categories that they knew didn't really fit everyone. But interestingly, as the NDIS has evolved, they have come to, from my observation at least, they've come to rely on these labels, these classifications better, more, because it's just easier for communication, easier for assessment. And so these arbitrary classifications, while they've got many shortcomings, it certainly does facilitate communications within systems, it seems to me.
100%. Yeah, absolutely. And I think that that's why the DSM is so embedded in how we approach the clear definitions that are offered makes it incredibly useful, much easier to operationalize than something that's more nebulous, that's more person-centered and really needs that deep, rich understanding of someone's context and experience. I agree.
So
That's why I
there's a
have that
difference
one
between,
slide where we talk about strengths before
oh,
moving
right.
on to the 30 slides of the, yeah.
So there's a difference between something being useful and something being accurate. And
Yeah.
maybe the DSM is really useful, but its accuracy is sort of in
Well,
question.
that's a pretty nice segue into my next section. Should I go into my,
Let's go.
yeah? Um, so I think, this really leads to that question of like, well, what's the alternative? I think looking at that evidence, it's clear that the traditional categorical approaches to classification are holding us back. But can we do better, right? It's obviously useful, but is there an alternative? There's lots of different groups of people working on this question about how we can reconceptualize psychopathology. So things you might be familiar with, like RDoC, the research domain criteria from the National Institute of Mental Health. There's dynamic systems and symptom networks, process-based approaches, and things like the power, threat, and meaning framework. But today I'm going to talk about the approach that's captured in the HiTOP framework, pardon me, which has a lot of overlap with that alternative model of personality disorders in section 3 of the DSM-5, if you're familiar with that. So we can go back to comorbidity because a cool literature emerged in the late 90s that started building on comorbidity, the patterns of comorbidity, not as a nuisance that undermines the validity of the diagnoses, but as a signal. So this is a figure from a paper that came out in the late 90s, starting to model these patterns of comorbidity and using here, we don't need to get into the statistics of it, but the oval is a latent variable and it's summarizing the patterns of comorbidity among these disorders. So it's really capturing that pattern of covariation. Here we have depression and anxiety disorders. Here we have antisocial personality and substance use disorders. And they gave rise to these ideas of internalizing and externalizing in adult psychopathology. This idea had been around for decades, since the 60s, from Tom Achenbach's work in kids, but this was the first time they were really brought into adult, particularly Axis 1 diagnoses. So here, internalizing is really the idea that people have a propensity for negative affect, broadly construed, and externalizing is more disinhibition-oriented psychopathology. That idea of expressing distress outwards is where the externalizing label came from. And a key point here is that these dimensions can be used in our research and practice rather than categorical DSM disorders. And what's cool about that approach, transforming categorical diagnoses into continuous dimensions, is that we can map where individuals sit on these dimensions, right? From low severity to high severity on each of these, the propensities for internalizing and externalizing. And everyone has a spot on each dimension. So we now have a lot of evidence that these dimensions are really useful and pretty amazing. We've got hundreds of studies showing that they provide useful targets for research and practice, and that they outperform traditional diagnoses in predicting a lot of things that we care about clinically, for example. So in terms of functional impairment, a 186% improvement in predicting self, informant, and clinician-rated impairment. For treatment needs, a 135% improvement in predicting which medications are prescribed. For course of illness, again, 135% improvement in predicting course of illness prospectively for up to 20 years. And they also align with the genetic structure of psychopathology and with key mechanisms in neuroscience. So these early findings really launched a new generation of research, integrating that dimensional approach that had already existed for kids and in personality disorders for a long time, and bringing them into traditional Axis 1 or clinical disorders, and starting to draw out these transdiagnostic dimensions, as they're called, because they cut across those diagnostic boundaries. So I've got a couple of slides here just to give you kind of a history of how this literature unfolded. People started looking at the dimensions that emerged in broader sets of disorders. So here, going beyond internalizing and externalizing in what were initially called the common mental disorders in this literature, to also think about things like schizophrenia spectrum disorders. And so that's where thought disorder came from. Often in this literature, people were interested in what is the structure of psychopathology? What are the right dimensions to describe it? And how many are there, for example? And so then we started to see different debates around things like sometimes internalizing was split into a fear, like a phobic anxiety, versus distress, that more negative affect kind of idea. And then for externalizing, you would sometimes see a split between antisocial behavior and substance use. So there wasn't one clean, clear set of constructs that was coming out. At the same time, the literature on the structure of personality disorders was emerging, where we see some familiar constructs here, and I'll focus on these 5, where we see negative affect, disinhibition or compulsivity and anancastia, antagonism or dissociality, detachment, and psychoticism. And this is an example of where one model was picked as the winner, right? So these are the 5 domains that are used in the alternative model of personality disorders in the DSM-5, where these are the broad domains that organize personality pathology when we take a dimensional approach. And they're also the domains that are used in the ICD-11 in the new fully dimensional approach to personality disorder classification. And so in this instance, the 5 were picked, but at the same time, or subsequently to these 2 literatures unfolding, there was a new literature that emerged on the joint structure of clinical and personality disorders together because of those parallels in the kinds of dimensions that were emerging. So there was that internalizing negative affect piece in both models, externalizing a detachment and pathological introversion kind of piece, and thought disorder or psychoticism. And in this literature, as people started to be able to look at broader and broader sets of diagnoses, there was also a somatoform spectrum that's kind of illness anxiety, health anxiety related. And so again, in this literature, sometimes we would find these broad domains, sometimes people would find narrower domains, and essentially there was a bunch of competing models. There was no real answer as to which one was the right model or the best model to use. And then about 20 years of that literature, after that had unfolded, a few people realized that a hierarchy might be a good answer to these questions, right? We can have our cake and eat it. We can keep all of the empirically derived constructs and organize them from the narrowest constructs nested under those broader ones up and up to the top. And it was these ideas that transdiagnostic dimensions are useful and that a hierarchy can integrate them into a single framework that led to the development of this new approach to classification in psychopathology called the Hierarchical Taxonomy of Psychopathology, or HiTOP for short. So specifically, to break it down, it's designed to follow the patterns in data. So we start with individual symptoms. And then very small sets of tightly bound individual symptoms form these things called homogeneous symptom components, right? So here we're looking at how symptoms tend to co-occur in the way that individuals experience them. Closely related sets of symptom components form broader syndromes. Closely related sets of syndromes are grouped under subfactors. Then we have these very broad spectra, which we'll spend more time on in a minute, that kind of organize I see them as the core of the framework. And then superspectra that can group multiple related spectra, like externalizing, for example, has the disinhibited versus antagonistic piece. And it's all of these pieces together that form HiTOP, right? So the HiTOP Research Consortium was formed in 2015 as what we called a grassroots effort to articulate a fully empirical classification of psychopathology. And specifically, the aim was to improve clinical practice and research by overcoming those limitations of traditional diagnoses. Here I've got a little circle, sexual problems. This was my PhD. This is why I got to be a part of HiTOP from the start. I looked at how depression, anxiety, and sexual dysfunctions were related to each other and concluded in my PhD that sexual problems could be a subfactor under internalizing. And I think that's probably wrong now. So I'm going to work on revising that, but it was my ticket in. And really, I think the key thing in this figure is the 6 core spectra. Because essentially, no matter which way we slice data, it doesn't matter what types of data we use, what statistical methods we use, which samples we use, we find these constructs as really useful organizing dimensions that come out again and again. So I just want to go through them to explain what those 6 constructs are. We've got internalizing that we've spoken about, which reflects a tendency to experience excessive negative emotions, things like depression, worry, and panic. We have disinhibition, which reflects excitement seeking, impulsive behavior, and drug or alcohol problems. Antagonism, which includes things like aggression, callousness, and grandiosity. Thought disorder, which includes experiences of delusions, hallucinations, or paranoia. Detachment, which is marked by low social drive and withdrawal from social interactions. And somatoform, which includes things like unexplained medical symptoms, as well as worry and reassurance seeking about the symptoms. And so these 6 spectra at the core, I think that a useful analogy is to compare them to the big 5 of personality research, right? Where if we look at someone's level of openness, conscientiousness, extroversion, agreeableness, and neuroticism, kind of gives us a big picture view of their personality. And we can do the same thing at the level of the spectra. If we look at people's symptom profiles across these 6 different domains, we get a big picture view of what their symptom profile is like, what it is that they're experiencing from a mental illness or psychopathology sort of perspective. So the next section is on, does it help? Do you have any questions you want to stop me with, Ben?
Oh, there's lots of questions. Rob asks, and he did touch on this a bit. He said, is the HiTOP predictive of future outcomes in any way? And I think a few slides back, you mentioned that it's just much better at predicting a few things than the DSM. Have I recalled that correctly?
Yeah, it certainly tends to come out that way. And in part because dimensions carry a lot more information than categories. And so they have an advantage in trying to predict things that we care about. And so, yes, it does do a good job at prospective prediction and tends to outperform particularly categorical operationalizations of DSM diagnoses.
Right. Kate asks, how does neurodivergence come into the model in terms of comorbidity? Also, is there work being done on a similar method of classification of neurodevelopmental presentations? So I do notice that an absence in HiTOP seems to be autism.
Yes, correct. And we will get to that. That's in
Okay,
two more chapters' time.
right.
Yes, you're right. That is a gap in what's there at the moment, and we do have some preliminary ideas on how it might fit in. But I might save that for when we get up to that bit.
All right, let's keep on going.
All right. So that's kind of a crash course on where HiTOP came from. But I think that it's really important to be thinking about how do these ideas overcome the limitations in the DSM and in this framework of like, does it help? Is it going to be something that actually makes a difference? So does HiTOP overcome the limitations of the DSM? In the first instance, there's kind of three key elements to HiTOP, which we've touched on. One is that it's data-driven, right? And this aspect of HiTOP, the data-driven feature, helps it overcome the first three limitations that we talked about in the DSM. So patterns of comorbidity are modeled as a signal rather than as a nuisance. The symptom repetition is only included when it's indicated by data that we need symptoms to be able to group together in multiple sections of the model. And the diagnostic heterogeneity is passed because we set up those tightly bound symptom levels. The lower level, we have only homogeneous constructs that are in there. The dimensional aspect as well, we just talked about this briefly, is really helpful in overcoming the latter three limitations, that dimensions have that inherent reliability advantage over categories because they carry more detailed information. So that means that inter-rater reliability and diagnostic instability are substantially improved. It means that differences in symptoms over time can be captured by slight changes up or down on dimensions of interest, and those arbitrary thresholds are gone. In addition to overcoming those core limitations, we also have the hierarchical structure of the framework, which gives us some added advantages, I would argue. So the hierarchy is really useful because it means that you can focus on the level of interest, right, for either a given research question or a clinical context. So for example, for research that's interested in a universal prevention focus, you can think about broad risk factors for psychopathology, things like childhood adversity, for example. But for research that wants to focus on the genetic determinants of auditory hallucinations, you can drill all the way down to individual symptoms. And similarly, for time-poor clinical settings, the focus might be on overarching severity, looking right at the top at how severe is psychopathology broadly construed. Or maybe looking at symptom elevations on the 6 core spectra, like we just talked about. But for a personalized treatment approach that has more time and resources available, then you can flesh out the full symptom profile that an individual has and track how their symptoms change over the course of treatment. So these advantages of a dimensional approach are so remarkable that even the DSM highlights them in the introduction. So the introduction says that a dimensional classification system will increase the reliability of mental disorders, communicate more clinical information, reflect reality more accurately, and will likely supersede the traditional categorical approach. I thought that was pretty striking when I read that for the first time. And so I guess that this is already, we've covered well over half of what I want to cover, but really we've been focusing on the benefits, the case for adopting HiTOP. And so what I want to turn now to is talking about some of the limitations of the research that's underpinning HiTOP. In part, it's self-serving because it's where I've been working for the last 5 years. I can show you some of the work that we're doing on strengthening the research base, but I also think it's a really important complement to have when we're talking about kind of this promotional lens of what HiTOP can offer. So one of the early critiques of studies modeling patterns of comorbidity, like that early one that we looked at with internalizing and externalizing, is the idea that diagnostic covariation or comorbidity just reflects that symptom overlap. We've got here, this is a quote from a commentary on an early paper in this space, that some disorders have a number of criteria in common, whereas other disorders do not. And if diagnoses are made without hierarchical exclusion rules, then disorders having more criteria in common will tend to covary more than disorders having fewer criteria in common, so really reflecting that symptom overlap. But this finding does not provide new empirical information. It is a direct result of the way the DSM is structured. In other words, given the DSM, these are the results you'll find. So essentially, this is just saying when disorders share lots of symptoms, people with those symptoms are going to be more likely to look like they have both disorders. And so that's what's giving rise to those transdiagnostic dimensions that were being found in that literature. And so for each of these limitations, I'm going to look briefly at some evidence that we can look at to understand that limitation or to overcome that limitation, address it to some extent. And in each of these, I'm just going to breeze pretty quickly through the next few slides, which have like a study on each of the slides, but I've got these little references at the bottom so you can read about them in more detail if you're interested. So to look at this criticism, the idea that it's just symptom repetition that's causing those dimensions to emerge, I looked at the patterns of symptom repetition in those diagnoses. So I found that 358 pairs of the diagnoses, which is 14% of all possible pairs that you can look at, had one or more overlapping symptoms, and that's what's plotted in this figure on the right. So each of the little black symptoms along the margins, each of the little black circles is a symptom, and then the lines show where that symptom belongs in the HiTOP framework. On the left, we have symptoms that reinforce the structure. We found that a third of the symptoms reinforce the structure, which means that we have disorders falling under a shared branch and they have shared symptoms, right? So that symptom repetition is making it more likely that the disorders co-vary. And about a fifth of the symptoms worked against the structure. So they were under different subfactors and different spectra, and they still had that symptom repetition. But probably the strongest pattern was that nearly all of the diagnoses had no shared symptoms, and most of the symptoms didn't influence the structure at all through repetition. And so my conclusion here is that it's unlikely that this is causing the kinds of things that we're finding, but it's likely to be an influence. It's likely to be in there. The second limitation is the idea that the HiTOP model is based on a narrative review. This is something that a lot of people don't necessarily realize if they haven't read the original paper. This is the figure 2 from the original paper that we published. And basically it's put together like a jigsaw puzzle of models that were already in the literature, those ones that we looked at where there were different competing models that emerged. And then this is like a summary, a schematic drawing of that review. And it was a really good start. It was important. It brought together lots of different people working in this space, synthesized the literature, got everyone on the same page. But it's not ideal for a framework that's kind of spruiking the benefits of being empirically derived. So a way we can overcome this limitation is by taking a meta-analytic approach, right? Rather than drawing a picture that summarizes a narrative review, we can actually quantitatively synthesize the literature. So in this study that Whitney Ringwald led, we pulled the data from 35 big studies on the structure of psychopathology, so more than 120,000 people's experiences, and it spanned 23 common and uncommon mental disorder diagnoses. And importantly, we used exploratory factor analyses. And I don't want to get too bogged down in statistics here, but it's important because we didn't take the HiTOP framework and say, can we fit this, to the correlation patterns that came out of those studies. Instead, we said, what are the structures that emerge naturally from the data if we let the data drive the patterns? And what we found was the spectrum level of HiTOP was really well supported, right? We found internalizing, detachment, thought disorder, antagonism, and disinhibition. And so really, this was a very important brick in the wall in the strength of the quantitative evidence underpinning the HiTOP framework. You'll see the dashed lines indicate there wasn't measurement of somatoform, so we didn't recover that. So this was a big one, that if we base it on a systematic review and then quantitatively pool the results, we find something that looks a heck of a lot like HiTOP. And a related limitation is that the evidence base really relies strongly on DSM diagnoses. So most of the evidence base summarized in this model, we can see here in the original figure that the diagnoses are placed in the middle to help people understand how to interpret the constructs that are in there. But essentially, most of the evidence base that's summarized relied on analyzing patterns of comorbidity or covariation among traditional DSM diagnoses. And this is because of the dominance of the DSM, right? It means that those constructs structure most of the big data sets that we have. But again, it's super ironic because HiTOP's based on the idea that we need to move beyond DSM diagnoses because of all of those limitations. And then they're a really big part of the foundation of the evidence base. So this means that things like symptom overlap and diagnostic heterogeneity are baked into many of those dimensions or much of the evidence that's summarized in the dimensions. And it also means that these lower levels of the model aren't well fleshed out, right? The symptom components and maladaptive traits and the signs and symptoms. In the original paper, we also had this figure 3 that lists some ideas for that lower level of the model, but it's really drawing on subscales of existing transdiagnostic measures, things like the PID-5, for example. And then we combined those two figures into this official model so that our revisions work group could have a place to revise from. So in terms of this limitation, right, that we're really relying on DSM diagnoses, what we can do to overcome it is we can take the diagnoses at the core of the evidence base, break them down into individual symptoms, and then rebuild the model from scratch. So that lets us address the fuzzy boundaries between diagnoses, heterogeneity within diagnoses, improve reliability of the constructs, and it lets us flesh out that detailed lower level of the model. And so we've just wrapped up a paper on this. We're going to submit it in the next week or two. So early research, spoiler alert. This was with my PhD student Tam Pham and her co-supervisor, my colleague and friend Carly Jonko. We looked at the data of about 15,000 participants in an online mental health study. And the way that we derived the model was we split the sample randomly into primary and holdout samples and took different statistical approaches, which is key because we only paid attention to the robust pieces, so where the different methods and the different samples arrived at the same structure. And we essentially, again, recovered the HiTOP framework. It's much more similar than I would have predicted. We don't have time to spend time on the details, but I can highlight these are the key differences. But essentially, other than those differences, nearly every construct in the current HiTOP model had partial or complete support when we took this approach. And so from my perspective, that similarity again is really remarkable, given all of the reasons that we had to expect that the limitations in DSM diagnoses might really be undermining the quality of the evidence that was summarized in a lot of those constructs. The last limitation that I'll spend time on from an empirical perspective is the idea that HiTOP has insufficient coverage of the DSM, which is what was just raised before when we stopped for questions. If we look here, we can see, let's go back here. We can see, again, the diagnoses kind of in the middle of the figure, and these cover 8 of the 19 chapters in the DSM-5 in full, and 6 of them in part, so often like 1 disorder from a chapter or 2 disorders, that kind of idea, which leaves us with five of the chapters that have no coverage at all in the current framework. And so again, thinking about, well, how can we start to address this limitation? We can rebuild it from all the symptoms in the DSM-5, right? So taking the same approach as in the study that we just looked at, so we've got the same data, and we actually had information on every symptom throughout the DSM-5, the ones that we looked at breaking down earlier in the presentation. Again, we only focused on cross-method and cross-sample robustness, so trying to really make sure we're only pulling at the threads that are sturdy. And we found a framework that looks like an expansion of what's in HiTOP currently. We went from about 71 diagnoses in the current HiTOP framework to 167, so we added nearly 100 diagnoses. And all we had to do was flesh out some of the lower levels of the subfactors and, like you were forecasting before, adding this additional branch of the hierarchy. So we have a neurodevelopmental and cognitive difficulties domain that emerged. So this really shows us a clear path to integrating nearly all of the content in the DSM into the HiTOP framework. It's not there yet, but we have the pieces in place to be able to do that. And that's related to the last big limitation I want to highlight from a research perspective, which is it's really hard to make change. So on a practical level, it's hard to make change to the HiTOP framework. This is an area we've been working on for years. We spent 5 years developing the protocol for making revisions to the framework, and then spent hundreds of hours of work to make this one tiny change, which we've made so far. We changed substance abuse to harmful substance use. And it's an important change, and it was stretching the legs of this revisions protocol that we've developed. But I would say that it's been a pretty humbling experience to realize how difficult it is to have a classification framework that's staying in step with the research evidence. We do have lots of work happening in this space, and because of this protocol that we've published, we are going to evolve as the evidence base evolves and not be driven and slowed down by social and political agendas like has often been hampering the DSM is the goal. But I think at an even more fundamental level, we can go back to this slide where we talked about the role of classification before. It's a really big ask to suggest that we change our classification system, right? It's deeply embedded in research, clinical assessment, treatment, our funding infrastructure, our insurance systems, public health and epidemiology efforts. It really drives our field, broadly construed, mental health in general. And it would be hugely expensive to make this change. We would need massive shifts in infrastructure, big changes to policy and funding systems. We would need a retraining, potentially, of the whole field. And so I think this really highlights the question of, is it useful enough? This really underpins where I'm moving with my work now. And I'm just going to spend 2 minutes talking about where I'm really excited to go from a research perspective. So what I've been thinking about, and in some of the work that I've showed you just before, is the idea of how can we translate DSM diagnoses into an empirically derived framework, kind of have a bridge between them. And I'll show you this figure from a paper that we published last year. Here on the left, we're looking at disorders that hung together well. So we can see under the DSM, we've got labels like intermittent explosive disorder, oppositional defiant disorder, and conduct disorder. And what we're seeing is that's the way that the DSM groups the symptoms in the diagnostic criteria for those diagnoses. And then the threads show where do those symptoms go in an empirically derived hierarchy of dimensions. When we follow the patterns in the data of how people experience the symptoms, where do those symptoms belong? And in the case of externalizing disorders, they pretty much all hang onto the externalizing spectrum and split across a bunch of subfactors. We've got other examples of diagnoses that hung together well: sexual dysfunctions, illness, anxiety, and somatic symptom disorders, a bunch of the eating disorders, anxiety disorders, and some of the neurocognitive domains. But we also had really important examples of diagnoses that were very heterogeneous. And pardon me, these are some of the big ones when we think about research and clinical practice. So things like manic episodes, schizophrenia, major depressive disorder, PTSD, autism, ADHD, for example. And so here we see that the symptoms, when we follow the patterns in how people experience them, they split across all of the different domains of the structure. They don't hang together as one coherent construct. And so what I'm interested in doing is thinking about, here we're just zooming into what major depression looks like in that figure, is focusing on these empirically derived pieces in traditional diagnoses. My work's already finding that these threads improve reliability over diagnoses and reduce heterogeneity from a variety of perspectives. And there's some early evidence that they can help us pin down mechanisms. So these symptoms that hang on the thread that's linked into distress, right? The symptoms that are bundled in that thread, they differentially respond to antidepressant medication versus CBT, for example. And the symptoms that load on dysregulated sleep and eating have unique associations with inflammatory biomarkers. And so what I think is exciting is if we think about, we go back to where we started, right? We want to design a study to learn about risks, consequences, mechanisms, and treatments. And what I think we can do is rescore the existing data that we have and study those empirically derived sets of symptoms within diagnoses. So rather than looking at the diagnostic construct as present or absent, we rescore it here. We've got a little gold dot to say that we're focusing on that distress thread. And we look at each of the individual's symptom levels on those constructs and study those. And then the idea is to figure out which sets of symptoms carry a reliable signal, help us get closer to pinning down mechanisms or treatment effects that are really obscured when we work with the heterogeneous diagnoses. And then the big picture is to figure out which ones work best, which work for what purposes, and when are they useful enough to justify those huge costs of moving away from traditional diagnoses. And so the last little section, I can stop for questions, Ben, but I also only have a few minutes left. Do you want me to keep going through to the end and then we can do a bigger Q&A?
Yeah, I reckon keep on going. There's lots of questions coming in. I'm writing them down, so we'll get to them at the end.
Yeah, awesome. And then we can give it some dedicated time and space. So I guess then thinking about kind of the clinical side of things, more like applying these ideas to individuals, I think that there's a lot of similarities to the research perspective we've been focusing on. So for example, there's good evidence HiTOP can overcome many of the limitations of traditional categorical diagnoses clinically as well. But we don't yet know if it's useful enough, that question of is it useful enough to warrant change in clinical practice. We don't have randomized control trials that show HiTOP outperforms traditional diagnoses for guiding treatment, or how to sequence or match treatments to the constructs in HiTOP with much precision. And so I'm going to show you here how it works at the level of an individual and then work you through kind of a high level overview of some key points and mostly point you in the right direction of where, oh, my lights went out. They're back. They're shutting me down for the night, telling me to go home, and point you in the right direction for where you can learn more from experts in the clinical applications specifically, if you're interested in that. So, for example, we can look at a fictional individual here, right? We can start at the level of the spectra, like we talked about as analogous to the big five before, and we can see that this person has elevated internalizing and detachment symptoms. And then the hierarchy lets us drill down to look at the specific symptom domains that are elevated in those spectra. So we see a handful of areas with elevated symptoms here. So in this case, it might work well to start with a transdiagnostic treatment like the Unified Protocol, which targets shared mechanisms, things like negative emotionality and emotion dysregulation, or SSRIs, for example, to target these multiple elevated domains together. And then we can use measurement-based care, track symptoms over time to make treatment decisions. So for example, here, if insomnia didn't respond to those kinds of approaches, then we could add sleep restriction or hypnotic drugs. It's important to note here, and I hope has been clear as we've been talking about it, that HiTOP is based on symptoms alone. It's based on those patterns of how symptoms go together in the ways that people experience them. So this means that distress and impairment need to be assessed separately to guide treatment planning. And it also means that we're not assessing information about environmental or contextual factors that might be causing or exacerbating symptoms. And so this kind of approach is really a complement to existing clinical expertise and the approach that many people would be using already. And actually, that's a key idea in the clinical feasibility space, that it builds on the idea that clinicians are already operating at the level of symptoms for treatment planning or for medication selection, case conceptualization, and communication. In that case, we just looked at, the idea is that you would be treating the depressed mood and the sleep difficulties, for example, rather than some hypothetical construct of major depressive disorder as the specific treatment target. So HiTOP really formalizes that approach into a structured hierarchy of dimensions, and it allows assessment and treatment planning at the level of relevance for the context that you're in. There's preliminary findings from field trials that are underway. There's, I believe, 15 outpatient clinics in the US using a HiTOP-informed approach that suggests it's easy to use, helpful for case formulation. And preliminary consultation with Australians with lived experience of mental illness suggests a preference for using dimensions rather than diagnostic labels, that they're less stigmatizing, for example. You can read all about in detail where the research is up to from a clinical translation perspective in this paper, which is the most recent review in that space. At the moment, I'd say that the best evidence for how to incorporate these ideas in clinical practice is not to chuck out the DSM and just use HiTOP, right? We're not there yet, but to hold traditional diagnoses loosely, to integrate dimensional thinking and assessment into your existing approach, and to incorporate measurement-based care in your practice. There's good evidence for all of those things. There's also a free workshop that's available that has more detailed practical information integrating HiTOP into clinical practice, and this group just published a paper documenting evidence that it's been really helpful for clinicians. And then finally, we've got some tools that are available to incorporate some of the ideas that we've talked about. So here, this is just a screenshot from our website with the practical tools drop down. Oh, you can't see my cursor, but the practical tools drop down, which includes clinical translation tools. So that's things like we've got a crosswalk from HiTOP constructs to relevant ICD codes for administrative or billing purposes. There's next down, pardon me, in the list, the new workshop. Then there's the new HiTOP self-report measures and adaptations, which can be used to directly assess HiTOP constructs. Ben's going to talk a bit about, we've got a brand new brief version of the measure. Looking forward to working with HiTOP or working with NovoPsych on that. And we also have projects that are underway at the moment on building HiTOP-aligned measures that include impairment and validity scales, clinical interview forms, modularized forms that let you focus on one piece of the framework at a time, and potentially with adaptive testing, informant versions, translations into multiple language, that's the HiTOP SR adaptations you can see in the drop-down, and a youth and adolescent version of the measure as well. And then at the bottom, you can see we have this clinical network shown on the screen. It's open to anyone who wants to learn more about using the model in practice. And it mostly just signs you up to get updates on relevant research instruments and treatment guidelines when they become available. In addition to those things, we've got the research consortium I mentioned before, if you happen to do research on quantitative classification. And we also have a new society that we've just started where we'd love to have clinicians join. And I'm running for president in a couple of weeks for that society. But I guess that from my perspective, the big picture is that all of it is just trying to help. It's not for profit. We're just trying to move things forward, overcome the limitations of traditional approaches to classification, and really have a big tent that welcomes everyone who's interested. So if you're interested in being involved in any capacity, I'm sure that there's kind of a space that can work well. And here's my contact details. I'd love to hear from you if we don't get a chance to chat at the end of today. And thanks very much to my research assistant, Tash Turner-Cohen, who did some of the work on those, like the cool slides with videos in the background and stuff like that. She's awesome. That's it.
They were indeed very cool slides. Now, let me share my screen for a moment before we get into the Q&A section. Um, So, one thing that, as many of you will know, Novopsych is all about measurement. How do we take research and then package it up into tools that are really useful in the clinical room? And so we're really pleased that the HiTOP consortium has let us put the Be HiTOP, which is a brief questionnaire on Novopsych, so that you can start thinking about clients in this way and measuring it as well. And so on my screen, I've got a graph that can be produced from the Be HiTOP measure. And I've also got a QR code. I'd really encourage you to get your phone out and open the link in the QR code, because um, it's an opportunity for you to self-assess yourself in the HiTOP framework. I often think that the best way to really understand a framework and start thinking in that framework is to do a self-assessment using that framework. So I encourage you to use that QR code right now before I go to the next slide, so that you can queue that up on your phone and do the 45 questions, and then get a little bit of a sense about your psychopathology as it fits into this framework. And of course, we are all in this together, especially that we're using a DSM, oh, not a DSM, a dimensional approach. It's not like, clinicians don't have any issues and clients have all the issues. We are all in this together, and the dimensional approach of HiTOP is a great way of exploring that in ourselves as well. Um, so I just want to show you how you can access the HiTOP and start using it in your practice right now. So right now I'm on novopsych.com, and to navigate to the Be HiTOP, I'm going to go to the assessment library, where we've got over 150 assessments that you can measure clients with. And if I search for HiTOP, um, I can have a look at this measure. And it says the brief Hierarchical Taxonomy of Psychopathology, or BHITOP, was developed by the HiTOP Consortium, and it's a 45 item self-report measure designed to provide broad screening assessments of dimensions that span the hierarchical structure of psychopathology in adults. And so what this measure does, it measures the um, six primary spectra that Miri talked about: internalizing, somatoform, detachment, thought disorder, disinhibition, and antagonism. And so you can see just from looking at this that some of these spectra will be quite high prevalence, like internalizing, which spans things like, anxiety and depression, whereas other things will be, much lower prevalence. But if you start using this scale with clients, it's essentially doing casting the net extremely widely, so you can measure a really wide variety of possible psychopathologies in your client, and which means it can be a fantastic place to start an assessment, um, uh, and and maybe even highlight some things that you weren't even thinking about. And if you give this HiTOP measure to a client, it will automatically score and give you a community percentile on those subscales, and it'll say whether someone's in a normal range or whether they're in the clinically significant or elevated range. And it will even give you a externalizing and P factor score. P factor, when I came across it, looking at all of this HiTOP literature, was such a fascinating concept, similar to the G factor that we use in intelligence testing for the general intelligence. P factor is a, um, a psychopathology factor, because we know that many of these different types of psychopathology co-vary. Moving down here, just to show you what sort of output this can give you, it will give you the results using percentiles of all of these, and also break down disinhibition and antagonism into externalizing, and then everything goes into that P factor. And then moving down even further, you can see that we've represented responses where the blue section represents where the majority of people within the community will score between the 25th and the 75th percentile. And those above the 75th percentile we've considered to be elevated, and those above, I think we called it the 90th percentile, or the 85th percentile rather, are clinically significant. And so what you're able to get when you administer this to a client is seeing which broad spectra are elevated compared to what you'd expect simply in a normative population. So if you want to get access to the Be HiTOP on NovoPsych, there's a couple of different ways you can do it. If you don't yet have a NovoPsych account, you can just simply press administer now, and I'd really encourage you to self-administer on yourself first so that you know what the measure is all about, what the questions are. And when you click that, what you'll see is a series of questions, and we'll ask people to rate them in the last 12 months. And you or the client can simply click through these, and then it will submit and send you the results in a PDF copy. But if you already have a NovoPsych account, what you can do is you can press login up here and log in to NovoPsych. So I've just logged into the NovoPsych platform. And so you can see today that I've administered the Be HiTOP to John Bloggs and a couple of times to dummy client today as well. And so if I go into, I'm going to go into dummy client, and I can see in dummy client that these responses, they've highlighted antagonism in red and disinhibition in yellow. So if I click into that, this is a sample of the results, of the PDF results that are automatically generated when you administer this scale. And so you can see for this particular respondent, they were in the normal range for lots of things except for disinhibition and antagonism. And then it graphs that in percentile terms as well. And scrolling down further, you can see that they're really in the normal range or even under the normal range for many things. Thought disorder was so low they didn't even get a score. They must have disagreed with all of the questions. But that disinhibition and antagonism were above this blue zone, indicating that it's a bit higher than what you'd expect the average person to be scoring. And so I'd encourage you to have a look at that. One thing I do want to highlight that we've put on here, and that Miri's talked about, that this is an evolving field, and that the HiTOP is, Miri's spending hours upon hours, as are dozens of other people. And so the HiTOP is really in active research. So we've put a little bit of a cautionary note here saying that the Be HiTOP is in active research. The results from this assessment should be interpreted with consideration of the evolving literature and evidence. And the ranges calculated here are based on preliminary norms that may be updated. So that's worth keeping in mind when you're using this. If you're using this, you're being a trailblazer, and you're conceptualizing your clients with the latest and evolving research. And one thing NovoPsych is hoping to do is to get all of our ducks in a row so that we can contribute to the development of this measure, working with Miri and the HiTOP team to further develop how this works. And if you do want to use the Be HiTOP within NovoPsych, but you don't want to be at the be contributing data to any upcoming research efforts, do have a look at the NovoPsych setting page where you can opt out of contributing any data. Some other things that are on NovoPsych that are really similar to the HiTOP and also empirically derived psychometric scales. Another one of my favorites, which is sort of a different dimension to the HiTOP, but instead of looking at psychopathology or symptoms, it's looking at personality pathology. And Miri mentioned this briefly as well. This is the personality inventory for DSM-5. And so what this does is really similar to HiTOP in that it conceptualizes personality with dimensions using these 5 structures: negative affectivity, detachment, antagonism, disinhibition, and psychoticism. And I think what I'm noticing in the psychometrics literature, and certainly where I think the field is going, for personality pathology as represented in the personality inventory for DSM-5 and also in the HiTOP, is empirically defined new constructs that don't quite fit how we'd usually talk about ideas within the DSM. For example, with this personality one, it also can categorize people in the traditional personality disorders, as we're so familiar with in the DSM, but it's only a secondary scores, whereas the primary way of doing it with these new, more empirically validated categories. And so hopefully me showing you these scales, particularly the HiTOP, and how you can start using these ideas and concepts that Miri and the team are putting so much hard work into developing. Hopefully it makes it super digestible and easy for you to use in your clinical practice, simply by navigating to this questionnaire and either pressing administer now or logging in if you've already got an account. So with that, we're going to do some Q&As. Hey, Miri, amazing slides, by the way. I don't think I've seen slides that are that nice. Well done.
Thanks.
So heaps of questions here. Let me read some to you. Tom mentions that the DSM faces issues with how arbitrary the diagnostic thresholds are. For example, 5 symptoms out of 9 or 6 or whatever. Tom highlights, in some senses, aren't all cutoffs arbitrary? And wouldn't that still be the case in a dimensional model like HiTOP?
I don't know if I would say all cutoffs are arbitrary, but you're right that it would introduce some of the similar limitations of a categorical approach. The fact that we need, for example, categorical distinctions about whether to treat is something that people bring up, right? But you can have the cutoffs like you have, where we can think about it relative to norms to see if symptoms are elevated, and think about it with reference to the distress and impairment elements to understand, is this something that needs to be a focus of treatment? I don't know that I would say that they're all arbitrary necessarily, not in the same sense as saying, yeah, that sounds about right. Right, that's arbitrary. You can also have things that are guided by data, informed by data, and that we test whether those cutoffs work well, whether they're justified. Things like, the hypertension cutoff, for example, is something that would have a lot of research around it. And I'm sure, I don't know the history of how all of the diagnoses in the DSM were developed, and it may well be that some of them have more evidence behind them than others.
Yeah. Nat asks, I'm interested in understanding how autism and ADHD fit into the HiTOP model, given that the symptoms overlap approximately 70%. I was really pleased to see that slide, Miri, where you've included developmental issues in there, because to me it felt like a gap. How is that evolving, and how are you going to approach that ADHD and autism crossover?
Yeah, that's a really good question. I want to put a paper in the chat that's looking at autism and ADHD in HiTOP. The idea is to incorporate a neurodevelopmental spectrum in the framework. Let me add it here. This summarizes most of the research that's been done in that space, and it's probably one of the biggest, most advanced proposals that I think is likely to be coming through in our revisions pipeline that I talked about. So I expect that that's the kind of change that will be made in the near future to
Right.
improve the coverage in the framework.
And Robin says, how does this approach help our society to move away from the dominant biomedical paradigm which bedevils so much of mental health interventions
Can you tell me
and
the start of the
discourse?
question again? I was distracted by the chat. Sorry, I'll stop looking at the chat.
How does this approach um, uh, help us move away from the dominant biomedical paradigm?
Well, I think when I think about the biomedical paradigm, I think about that kind of idea that we've got these underlying disease entities, right? Like we're treating major depression as a thing that exists somewhere, right? That we should have been able to find when we sequence the genome or image the brain. That it's like, there it is. We can like something that's real in that sense. Whereas I think that what a lot of those limitations we talked about suggest is there isn't there isn't some kernel that we're going to be able to find where it's like that's depression, there it is, and now we know how to treat it. It's more about moving away from that, what we would call the medical model, that sort of idea of this underlying disease entity that's causing the symptoms, and instead thinking about utility, thinking about what's a useful way that we can diagnose, assess, classify mental illness, psychopathology broadly construed, and then use that in a way that can actually lead to these advances that we've been missing in research and practice. That's how I think about it as different. It's kind of like I was saying, holding diagnoses loosely, not thinking of them as necessarily real categories that exist in nature.
Yeah. And the thing I love about high top and dimensional models in general is that they're that by their very nature dynamic in that there's an appreciation that people move up and down from day to day. You know, some days my P factor is much higher than others.
Mm.
And yeah, and I like the way that it doesn't, say, us and them, or you've got a mental health disorder or you don't. It's all continuous. Speaking of which, Bennett asks or comments, unfortunately, psychologists only have disorder language to describe neurodivergence and other issues. Um, how does the high top grapple with that pathologizing nature of things? I suppose baked
Mm.
into the high top is it uses the word psychopathology. So
Yeah,
it
yeah.
really is about that, isn't it?
Yeah, no, I agree. I think that that's something I have changed in my thinking to thinking of it more like a hierarchy of individual differences, right? That there
Right.
isn't some implication that what's listed in the framework is psychopathology and what's not isn't. There isn't some clear border that we can draw around that. It's more like what's the useful information we can use to triangulate the information that we want to understand, right? And so definitely in the perspective of neurodiversity, the idea of including it and pathologizing just normative variation in human experience is an important consideration. I think that probably a lot of work needs to be done in that space, which isn't something that I have a lot of expertise in, but with co-design, with working with people with lived experience and in the communities that to say, how would it work? What would it be like to include this in a dimensional classification framework? And maybe it needs something like a name change, right? That it's not the
Yeah.
hierarchical taxonomy of psychopathology, which is inherently pathologizing. But I agree that that's a really important thing to consider.
We've got a question here. Someone's asked, can you come back to the Ocean Big Five model of personality and
Mm.
expand more on what you meant about comparing it to spectra?
Well, I guess that. The reason I like the analogy between them is because there's so many parallels, right? Like everyone has a place on the externalizing dimension, right? You're somewhere from, oh, sorry, extroversion. I'm really tired. Everyone has a place on the extroversion dimension, somewhere from super introverted to super extroverted. We all have a spot on that dimension. Like you say, it can change over time and in different contexts. But it's this same idea of thinking about, we can summarize someone's personality with those 5 dimensions. You look at where do they sit on openness, conscientiousness, extroversion, agreeableness, and neuroticism, and you have a picture of what their personality is like. And so I think of that as analogous to the spectra. And even in a lot of instances, there's a lot of research on the idea that they're kind of like the pathological end of the same dimensions in a lot of cases, right?
Exactly
That
right.
internalizing is super neuroticism related. And what's another example in there?
Well, yeah, I mean, on the big five, you can be highly extroverted or introverted.
Mm.
But on the PID5, which is the psychopathology version, that's called detachment. So it's
Yeah, no,
essentially on the
that's another
same
good one. Yeah,
dimension.
totally. Yeah.
It's just that one uses pathologizing language and the other sort of doesn't. Um, uh, John says, how might the HiTOP model help in treatment planning or approach to intervention? What's your sense of that?
Yeah, I think the kinds of things we were talking about towards the end, if you can understand broadly where people's symptoms are more elevated, right? Like in that example we looked at, we can see internalizing and detachment, and you can drill down just one level in the hierarchy to get a sense of, well, which specific kinds of areas are they tending to see notably elevated symptoms? I
Yeah,
think that kind of picture that lets you take off the diagnostic blinders, right? You're not just thinking about what is the correct label or which box does someone fit in. I'm not implying that that's how a lot of people would work in practice, but I think that the idea is to think broadly, transdiagnostically from the outset. You're not going to miss things if you're taking this kind of evidence-based, measurement-based care approach to thinking about what is someone experiencing and then focusing treatment on that.
yeah. And I would say, at work in the clinic, when I'm in the clinic, around the lunchroom, where all of the psychologists are familiar with HiTOP. I've introduced it to many of them, and just around the language that we use in the lunchroom around how to communicate. We say things like, where are they on the P factor? Where are they on are they high on antagonism?
Mhm.
And having this shared lexicon does help us think differently and therefore plan interventions better. And I'm seeing that among treating psychologists.
Yeah, I mean,
Miri,
remember, I'm not a clinician. We have to keep just, I repeat that each time I answer a question. This is it.
yeah.
Yeah.
Miri, thank you so much for tonight. The depth of knowledge is absolutely incredible, and it looks to me like you covered things on one slide that probably took um, years to articulate. And I
Yeah.
did like the fact that you said that your PhD on sexual functioning, you now think that your whole PhD was wrong.
Yeah, I'm
So
pretty sure it
it
was.
it takes a great deal of intellectual honesty to admit that. And so thank you for all of the work that you're doing. And for everyone attending tonight, thank you for attending. It's a real testament to the mental health community's commitment to continually improving our standards in the service of our clients. So thank you for taking time out tonight to do that. If you're not yet using NovoPsych, I'd encourage you to give it a go and activate a free account. There's a QR code on the screen that you can use, and if you get your phone out and take a photo of that, you'll be able to sign up to get access to the HiTOP with automated scoring and everything else we have on offer. So thank you once again for everyone coming, and Miri, for your deep expertise.
Yeah,
If
thanks everyone for your time tonight, definitely.
we do have another webinar coming up in November on eating disorders, so if you enjoyed this one, do come along to the next one, and I hope to see you there. Bye.